Let's start with pulseless electrical activity and asystole. All right, guys, I'm going to introduce you to your first two rhythms. Sinus rhythm without a pulse is called pulseless electrical activity, and asystole. Guys, these are lethal rhythms. There's no cardiac output, no perfusion. The person is clinically dead. What do we need to know about this rhythm? First, PEA looks like sinus rhythm, but guess what? The patient does not have a pulse. So what do you need to do? You need to check for the cause. There are four H's that are going to come into the next segment and four T's that we're going to talk about in the next segment. You need to know about what's happening. You need to fix it and then treat the rhythm. Okay, the rhythm is going to rebound. So first, asystole, there's no cardiac output, no life, no heartbeat. They have no rhythm at all. Pulseless electrical activity, let's look at that a little bit closer. What do you need? Epi. Epi every 5 minutes. Every 5 minutes. Epi Q 5 minutes. What else do you need for this? Once you've given your first epi, but how do you give the epi? We need something else. I'm going to put it in the middle here. You need three things: airway, IV, and then epi. Airway, IV, and then epi. What does that mean? Once the patient comes in with low perfusion, low cardiac output, no blood pressure, no pulse, you need to call the code, get the crash card, and then do what? Get your airway in. After you get the airway in, you want to put in your what? IV. Once you would have established that this is a pulseless electrical activity, it looks like sinus rhythm, but the patient does not have a pulse, then you need to give your epi. You want to give epi every 3 to 5 minutes. 3 to 5 minutes. And then you want to consider what? You want to consider the causes. That's right. There are four H's and four T's. We're going to talk about the H in the next segment. T, cardiac tamponade. What's the next one? That's right, pneumothorax. So tension, pneumothorax. What's the other two? Good. I'm going to let you figure that out in the next segment. Okay, we're going to do something. What happens here? When you have tension in the chest cavity, what are you doing here? You're bagging this patient. You're trying to open the airway. If you feel that this patient, the air is not going into the lungs is not expanding, then you need to consider tension pneumothorax. After 20 minutes of dealing with this patient, then you want to consider to stop the code. What happens after 20 minutes, the body goes into a very acidotic state, and it starts to compensate and then start to fight against itself. So let's look at sinus rhythm, pulseless electrical activity again. PEA, pulseless electrical activity. You want to give epinephrine every 3 to 5 minutes. You would have already recognized that the patient has sinus rhythm on the monitor, but no pulse. You would have activated the code, open the airway, start bagging, have your ET2 stuff available. You want to put in an IV, very large bore IV. A good practice is you want to put it in both arms, because remember this cardiac output is his vascular system is going to collapse, so you wouldn't be able to do it in a few minutes. Then you want to start your epi. You want to give epinephrine every 3 to 5 minutes. You want to consider your four H's and your four T's. You want to fix it. Fix it. Okay? You want to fix the problem. Once the problem is fixed, then the PEA may be resolved. Okay? So consider your collapsed lungs with your tension pneumothorax there. Asystole, everybody knows the flat line. Everybody knows the flat line. What do you do for asystole? Asystole, you walk in, there's a flat line, the patient is not breathing, there's no heart rate, airway, IV, epi. But what do you want to do first? You want to do CPR. That is the difference between your pulses electrical activity. Pulses electrical activity, you want to go ahead right away and fix the problem. Okay, this person is not flatlined as yet. This one here, airway, IV, epi, CPR, airway, IV, epi. You want to do what? CPR. After you would have done this for about 15 minutes or so, you want to consider amiodarone. Remember, with amiodarone, there you have a standard dosage. You can go IV or IO, intraos. If you're going to give it, you're going to give 300 milligrams first. IV or intraos. You want to give 300 milligrams first. If you don't have any changes, the heart rate doesn't come back, you want to go ahead and do 100. Your second dose would be 150 milligrams. Okay? So that is very simple. Again, with asystole, this patient may have progressed from PEA to asystole. So what do you think is added in this algorithm? Yeah, you have 4 H's and you have 4 T's. Okay, you want to consider those. You want to fix it. This person is on an overdrug, had ingested some opioids, and he's overdosed. You need to fix it. If you fix it, patient may come back. Okay, so our next rhythm is Brady. Brady is not as bad as our previous 2 rhythms, which was asystole and PEA. Now, in that previous video, I may have said 30 milligrams of amiodarone. Remember, it's 300 milligrams of amiodarone. Okay, just want to make that clear. Followed by a second bolus of 150. Now, Brady is not as bad unless it's unstable. Do you remember unstable? Remember, I told you you're going to have to remember this. The collapse method. When we talk about collapse last week, we talk about C for what? Chest pain. A patient that has chest pain is considered unstable. Then O. What is O? Low oxygen. A patient who is unstable may have what? Low oxygen. Then of course you have your lightheadedness. What is your other L for? Low blood pressure. So low blood pressure, lightheadedness, chest pain, low oxygen. Then we have A, P, and S. What is the A for? Anxiety and palpitation. And of course the good old shortness of breath. And what is the E for? You could have elevated heart rate, or you could have decreased heart rate. But in most cases, when you are anxious, when you're compensated, you're going to have increased heart rate first. Okay? And then, of course, D, dizziness. Okay? So bradycardia is not as bad if it's stable. Stable, what do you do for stable? Nothing. You remember your athletes could have bradycardia, a person who's on beta blockers, so athletes, athletics, beta blockers. Okay, so you need to ask your patient, is he or she on any beta blockers? But if the patient does not say that they're having any of the signs that is related to unstable, then you just leave them alone. Now, what do we do for unstable? What is the drug of choice? Now you're going to hear adenosine and you're going to hear atropine. You're going to hear adenosine and you're going to hear atropine. Anytime you hear the word atropine, we know that's going to do what? Speed up the heart. When you hear about what? Adenosine, then you know it's going to do what? Slow down your heart. So when we talk about sinus tachycardia, hello, we're going to have adenosine. When we talk about bradycardia, we're going to give atropine. Now, atropine has a maximum dose of 3 milligrams. We have to remember that. Atropine has a maximum dose of 3 milligrams, maximum. Now, there are lots of reasons why a person would have bradycardia. Several of them comes right back. See, this is why you need to know your 4 H's and your 4 T's. These are reasons why a person will have bradycardia. Now, atropine is given in from 0.5 milligrams to 1 milligram. So you can start off with 0.5 to 1 milligram. But here's the trick. If your patient is very, 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 very sick, that means his his heart rate is below 50, and he is showing signs of unstableness, we could say that this person is unstable. When that person is unstable, what do you want to do? You want to start with the higher dose, which is 1 milligram. So you can give him that every 3 to 5 minutes with a maximum dose of 3 milligrams. If the patient is stable, that's this patient here, even though he doesn't have signs, the doctor might say, you know what, I want to just get your heart rate up. Just give him something to bump the heart rate up. But remember, you don't have to do anything here. But if the doctor decides to say, you know what, you've been 53 too long, or 48, before you become symptomatic, let me give you something. He's going to start on the low dose, okay? So consider this one alive. Anyone who's alive and well, this one who is dying, who's going to be dead, 1 milligrams every 3 to 5 minutes. Now, once you give the atropine every 3 to 5 minutes, the max dose, and that doesn't work, then you have another treatment. Notice I did not talk about bring out the defibrillator. The defibrillator is not in this algorithm, okay? Atropine is in this algorithm. What do you want to do next? Transcutaneous pacing, okay? Transcutaneous pacing. What does that mean? You put the pacer on the patient, and you could do it 2 ways. There's a pad that's placed on the patient's chest. So this patient, I'm going to do something here. He has the rhythm, there's a pause. He has a rhythm, there's a pause. He has a rhythm, he has a pause, okay? What happens is, when you put the pacer on, the pacer then does what? Comes in and kicks in the pause. So when this patient was having a heart rate of 1, 2, 3, because you know you're checking your R's, you're counting your R's. He's going at 30, and 1 R is equal to 10. So that's 30 beats a minute. Here comes the pacer. You set your pacer actually. So you'll set your pacer, if the patient goes at 30 but you want him at 60, the pacer knows to bring him up to 60. So in this case I set it at 50, and look what happens. 1, 2, 3, then the pacer kicks in. Now you have 60 beats per minute instead of 30 beats per minute. So we just looked at sinus brady. Brady is slow. So now we're going to look at sinus tachycardia, and sinus ventricular tachycardia, SVT. Okay? So now, what is the difference? The difference between sinus V-tach and sinus tachycardia is 150 to 250. 100 to 150. So when you look at your patient who's in sinus tachycardia, you're looking at a rate of 100 to 150. Sinus V-tach will be anything greater than 150 to 250. Just like sinus brady, you have the stable patient and the unstable patient. Your unstable patient, remember, is complaining of chest pain. You look at the oxygen rate on the measurement of the SpO2, that is low. He's complaining of lightheadedness, any of the above. He doesn't have to have all of the collapse. It could be anxiety, shortness of breath, elevated blood pressure, and yet dizziness. So what then is the treatment? For stable, any drug, any of your betas, blockers that reduces the heart rate, you want to give the patient. Okay, your Procardia, your Amiodarone, 150 milligrams you want to give. Sotalol, Lopressor, any one of the drugs that are beta block. Patient is stable. There's no complaints of chest pain or anything. The unstable now, let me get my different color marker here. The unstable patient, what do you want to do for him? You want to cardiovert. Now see? You want to cardiovert that patient. In your sinus Brady, we did transcutaneous pacing. For your sinus tax, we want to cardiovert. On your defibrillator machine, on the machine, on the crash cart, there is a little dial. The dial switches from defibrillation to cardioversion. So make sure that you're not defibrillating a patient that is unstable sinus tachycardia. There is a number that you need to remember. You want to give 50 joules. That's what you want to start off. Anywhere from 50 to 100. So of course, if this patient is symptomatic at 100 and 120, we probably could start at 50. If he's symptomatic at 150, because we don't want him to get into this mode, okay? We can give him the maximum, which is 100. But you could do it 50 and then 50 and see what happens. Most of the times, the doctor would stagger it, okay? So you want to cardiovert. Just like your TCP, transcutaneous pacing, you need to sedate first. That's your job as a nurse. Sedate your patient, cardiovert, and then 50 to 100 joules, J-U-O-L-E-S, of energy you want to give the patient. Now, we didn't do a good job, and the patient goes into SVT. Now, in this case, we didn't find out what was the problem, but remember, anything that is metabolic can cause SVT. Anxiety can cause it. Problems in your atrium, which we're going to talk about later, can cause it. Fever can cause it. The first thing you want to do is fix the problem. What is causing this problem? Is it something in the atrium? Is it the fever? There are some things that we can do as nurses, but before we get to that, now we need to try and slow it down. So someone is simultaneously trying to fix the problem while we are trying to slow it down. So what do you think the medication of choice is? Is it atropine? Is it dopamine? Is it adenosine? That's what it is. Adenosine also has a maximum dose. So you want to give 6 milligrams first, followed by 12 milligrams. Okay? So you want to give him the 6 milligrams, see if that'll bring it down. Then you want to give the 12 milligrams. Adenosine is the brakes of the heart. Okay? Atropine is the brake release. Okay? So you need that patient to start rolling. This one we needed to stop. So we want to give 6 milligrams first every 3 to 5 seconds. Now, 2 things you need to do. Just like in any rhythm, you have to make sure you have your airway and your IV. Preferably in both arms. This is the tube, the IV tube. This is the tube going up to the IV bottle. Okay? When you push, sorry, this is not the bottle, the patient heart. Okay? What happens now is when you put the 6 milligram in, it stays right in the tube. It doesn't go anywhere. And you're trying to figure out why this patient heart rate isn't going down. You must flush 20 cc's fast after you give your adenosine. You want that to reach the heart. Fast flush of 20 cc's of normal saline. You need to do that fast. So we looked at asystole and we looked at PEA, asystole and PEA. Then we look at bradycardia, stable and unstable, reminding ourselves about the collapse, unstable. Then we look at sinus tachycardia, stable and unstable. Then we looked at SVT. Now we're going to look at the big guys. That is ventricular tachycardia. Again, stable and unstable. Then pulseless VTAC. VTAC, stable and unstable. Then pulseless VTAC. Then VFib. The good thing about this is the treatment is defibrillation. Only in this point here, we're going to go synchronized cardioversion. But everything else, then to SAD's the point, okay? When you have your low magnesium in the body, okay? When potassium walk in, magnesium walks out. So in this case, the patient is having an MI. Remember last week, MI, increased potassium, when magnesium walks out. This treatment is very easy. If your magnesium is low, you just need 2 milligrams of magnesium. But here's the trick. I'm going to show you this. It's going to sound crazy, but I want you to just sing it in your mind, okay? So I'm going to do this 3 times. So what did I just do? I shocked the patient, I put in the IV, and then I did CPR. So I shocked the patient, I put in something in the IV, and then I did CPR. I shocked the patient, I put in the IV, and I did CPR. Shock, IV, CPR. Remember that. Shock, IV, CPR. Remember that. Shock, IV, CPR. One more time, because it's 3 times. Shock, IV, and then CPR. And so, we're back again. VTAC, stable and unstable. Now, we're going to, in another lesson, we're going to look at, remember you have to be able to recognize these rhythms, okay? Everybody say defibrillate, defibrillate, defibrillate. These are the rhythms to defibrillate, all right? VTAC, that is unstable, pulses VTAC and VFib. So, there is a strip that I'm going to show you later so we can know what it looks like. So if you have a monomorphic, stable patient in your box, in your treatment box, you want to synchronize cardiovert. Again, before you synchronize cardiovert, you want to sedate the patient. You want to do what? You want to give 50 to 100 joules. This synchronized cardioversion is found on your defibrillator. All you have to do is look at the button, switch it over, make sure you're not defibrillating this patient. If the patient is unstable, the patient shows signs of collapse, unstable, then we go to polymorphic. We go to polymorphic rhythm. Now, remember my little crazy move just now? What is the treatment for unstable polymorphic pulseless VTAC? That means that it's VTAC without a pulse. VTAC without a pulse. Remember that before when we had sinus rhythm without a pulse? That was PEA. Now we have pulseless VTAC. What then is the treatment for that? Remember my rhythm. Shock, IV, CPR. Shock, IV, CPR. How many times? 3 times. So the first shock, you're going to start with 120 joules. This time is not cardio, but you have to be on the shocking mode. I'm clear, you clear, everybody clear. Shock. Doctor's going to say, or the person who's running the code, 120 joules. Then somebody's going to come and give an IV dose of epinephrine. 1 milligram. Every 3 to 5 minutes. So, 3 to 5 minutes, what am I doing? CPR. Circulating Remember, this person is flat-lying. There's no blood, no perfusion from the heart. Cardiac output is low. SVR is high. We need to do what? Circulate that epinephrine, CPR. So after about 2 to 3 minutes, we're now back again to do what? Shock, IV, CPR. This time we're going to give how many joules, how much shock are you going to put on this patient? You're going to give 200 joules. Then, who's going to be given the IV? IV, 1 milligram every 3 to 5 minutes. Then we need to circulate it by doing what? CPR. Then the third one, shock, IV, CPR. What is the third shock? You want to stack it up. You want to give them a higher joules. 300 joules. Shock, IV, CPR. Shock, IV, CPR. So you want to give 120 millijoules, 200 joules, followed by 300. Push your IV of epinephrine every 3 to 5 minutes. Then you do a cycle of CPR. That's about 2 to 3 minutes. Then you shock again, and by the time you've done that, you're back to your epinephrine again. If the patient has not rebound, then you want to give him amiodarone again. You remember we give this drug before. 300 milligrams, followed by what? 150 milligrams, okay? And that will do your pulseless VTAC. Everybody's so afraid of this. These are the lethal rhythms. This is where a patient is probably having a heart attack. And a lot of people are afraid of the actual defibrillation process. It's so easy. Shock IV CPR. Guess what? Now we're going to talk about VFib. The easy thing about VFib is the exact same thing as pulseless VTAC. If you recognize what VTAC looks like, you check the patient's pulse. He has no pulse, but it looks like VTAC. That means he's pulseless VTAC. This patient needs to get shocked. When you look at the patient and he has the VTAC, when you look at the monitor, but he has a pulse, he's stable, sedate, synchronized, and cardiovert. Now, what happens now after a long QT? You remember your QP, QRST, okay? So P, Q, right there, Q, R, S, T, okay? So when you have a prolonged QT interval, it looks like this, okay? So this, when you look to see what VFibs look like, it's a long QT interval, rapidly going. This patient needs shock, IV CPR. Now, because you have that IV in there, you're going to go ahead, you're going to draw some labs. The patient can either progress or digress to SADS the point. The SADS the point normally comes about when your magnesium is low. This is your heart. Your heart operates on electrolytes. What happens is when your heart, when your potassium level, remember one of the indications for a heart attack is increased potassium. In our last segment, we looked at one or two of the most lethal rhythms, your ventricular fibrillation and your pulseless VTAC. Now we're going to look at the Brady's, which is the heart blocks, your heart blocks. This is where you will probably get your transcutaneous pacing, or the patient may end up with a pacemaker. So here now, this is so easy to follow, this little thing here. You have first degree heart block. The AV node is not working as it should. So the heart is it's going very, very slow. So first degree, second degree type 1, second degree type 2, and then your third degree, okay? So you have your first degree, second degree, and then your third degree. So there are two types in your second degree. So look at this, your first degree, what's happening there? In your first degree, your P wave is prolonged. It's greater than 0.20 seconds. Prolonged. not only is it prolonged, it is a constant prolong. It's constant. So you see, just say this is point greater than 2.2 seconds. Just say this is 0.25. You see that there? So the next P wave, so you have a P, then you have your QRS, then you have your P again. It's going to be the same 0.25, constant. All right. So your AV is not working as it should. It holds the impulse that it sends to the ventricle, but the ventricle is normal. It's prolonged. Your first degree is greater than 0.2 seconds. But look at this. This is constant, but it's same 2.5, same 2.5. The person's in first degree. Your second degree type 1, it's irregular. The second degree type 1 is irregular. Look at this. Your first P comes, then you have your QRS, right? Your next second P comes, you have your QRS. Your third P, a QRS, and then so forth, right? So what happens then, all of a sudden, then it drops, okay? It does not produce a QRS. And then it starts again, okay? Look at this here. You have short, I'm sorry, it's not short, long, longer, okay? And then your QRS just drops off. There is no QRS. Then it does it again. Long, longer, QRS drops, okay? It's irregular, all right? In this second degree, type 2, it's constant. So if you have anything that's greater than 0.2 seconds, just say this is 0.25, 0.25 is the same size. This is 0.25, this is 0.28, 0.30, 0.34. You see? This here is constant. We're going to go with a number that's easy, 0.25. Then there is no QRS. It does not produce a QRS. Same thing happens again. Constant, 0.25, PQRS. Then no QRS. Okay, type 2 is constant. Third degree, there's no relation between PQRS. You can't say it's going to be constant. So let's end with third degree. In third degree, you have a P, a QR, and the P drops off. Then you have another P, QR, P drops off. Then you have a P, QR, and then the P comes back home. The ventricles are repolarizing. So what you have here, P, drop off, P, drop off, P, P. So your P's are just dropping off. There's no relationship between your P waves and your QRS. No relationship. Unlike this one here, there was a relationship. You have like 3 sets of PQRS, then there's no QRS. 3 sets, there's no QRS. Then you have long, longer, and then you have a drop off. But here in your third degree, you have your P, then there's a drop off of a P. A P comes back, then it drops off, and then you have a P again, and then a P again.